Hello, everyone. Welcome to Fertility Factor Fiction. I am your host, Dr. Rahi Victory, newly back with very limited vocal range from Germany. And when I say newly, I mean I literally arrived at the office about 10 minutes ago. So I just got back from a trip to Berlin where we were helping out. A conference about fertility and helping Europeans who are trying to have babies. So, welcome back to the show. Thank you for watching, for those of you that watch. Not a whole lot going on out there in the fertility world recently, although there is an upcoming study which we will review yet again on the ERA test, which now demonstrates that if you properly calculate the statistics from the ERA study done by the people that produced the ERA test, that it's actually detrimental. And the interesting thing was that I shared this with a colleague recently who claimed that they still use it thinking that it works, but it very clearly doesn't work. So I was quite shocked to hear that. In any event, so yeah, the ERA test is like officially dead. Don't do it. And if anybody suggests that you do it, they're not reading properly, in my opinion.
Definitely didn't watch the show before.
And definitely did, yeah, and hasn't watched our show before for sure. Although I do have a tremendous amount of respect for this one particular colleague, so this individual may be aware of stuff I'm not. So I should say that before I speak ill of the ERA test. So yeah, otherwise, nothing too exciting. There was also a interesting rebuttal from Dr. Casper in the Journal of Assisted Reproduction and Genetics in regards to a study which came out literally the month after he published his, where he said that if you have a low number of embryos, you should not do PGT. And there was another study that came out saying actually you should, but then he looked at how they did their data analysis and demonstrated that their data analysis is wrong, that you actually get half the rate of live births when you did the PGT. None of that's relevant though, because neither of those two studies were randomized controlled trials. So we need a better system to do this and a better study. And I would love to ask all of the huge centers out there who are doing thousands and thousands of cycles per year why they haven't done that yet. Because either someone knows the answer and doesn't want to publish it, which would very much mean PGT is not useful because lots of people have invested into it, or for whatever reason, people just haven't come out with the properly done study yet. I'm not sure which one it is, and there's no way to know until someone actually does the study, but I think it's important that we get that done. So it should be interesting to find out. Anyways, tonight's going to be questions only because I do not have anything prepared for you because there wasn't really anything great out yet except for that ERA study, and I figured since we missed you last week, you'd probably want to ask some questions. I am very scruffy, so I apologize for not looking particularly sharp, but here I am. So fire away. What are our questions for tonight?
You look incredible.
Oh, thank you.
With a hint of sunlight.
Yes, I was visiting the Sachsenhausen concentration camp outside of Berlin and in Oranienburg. And it is a bit of a life-altering experience. So I did not have sunshade on or any protection, and so I was outside on their grounds for most of yesterday. Wow, shocking what human beings can do to each other. And I actually am even happier about what I do because it's such an opposite to what I saw yesterday, where you can really see how low humanity can sink and deprive people of their livelihood and their life. And here we create life. So it was really kind of reassuring to be part of what we are and to be part of the team that I'm a part of. So yeah, very shocking experience. If you ever have the chance to do it, you should do it. Fire away.
How do you thicken lining before FET? Don't want estrogen because history of fibroids and signs of dominance.
Yeah. Actually, somebody asked us to create a video for that, so we should do that.
Great.
Yeah. I don't know if we have time this weekend, but maybe we will. So there's lots of ways to thicken the lining without using estrogen. Letrozole is a suitable alternative, which keeps your estrogen low, but still thickens your lining reasonably. PRP, vitamin C, D, and E have all been shown to do it. Baby aspirin can do it. Pentoxifylline can do it. Vaginal Viagra can do it. So all of those are reasonable approaches if you're trying to keep your estrogen level low. There is also the opportunity to do it with stimulation, but that's not keeping your estrogen levels very low. So all of those things are possibilities for you.
Obviously, you ended that way too quick.
And if you're new to the show, we answer your fertility questions live. So don't hesitate to ask your questions. I see people jumping in and out of TikTok all the time. So yeah, if you have questions for us about fertility, let us know. And we're always happy to answer questions. Or gynae or OB, right?
Yeah, that's right. It's very
Yeah,
important.
yeah.
Hola, Dr. VNT.
Hola, ¿cómo
I
está?
have a first consult with you in June.
Okay.
Any specific labs or information you would like me to have ready for that day? Can't wait.
Oh,
Hearts.
hearts. Well, thank you. I look forward to seeing you. So yeah, I mean, basic labs, AMH, your hormones, FSH, TSH, prolactin, LH, that kind of thing. Sperm analysis and any ultrasound findings that you've had would be great. All of those would be very useful. Yeah, so anything like that you've got would be helpful. If you have, additional labs from anything that they've done, vitamin levels, in particular vitamin D, that can be useful too.
When do you administer in the timeline uterine PRP and Neupogen for FET?
Neupogen is supposed to be 5 days before. PRP is supposed to be 2 days before in the majority of the studies I've read. That's if it's for unexplained failures. If you're trying to thicken the lining, it's a month before for PRP. Neupogen, you can probably still do 5 days before.
If one of your patients is diagnosed with endo, what is your protocol before an FET?
Oh boy, we get asked this all the time. I think we need like a short.
100%.
That would be a good short. Yeah. Okay. So Lupron for 3 months with letrozole every day before the FET, and then a letrozole-based FET with minimal to no estrogen, and then supplements. So resveratrol, NAC, coenzyme Q10, curcumin, and ALA, alpha lipoic acid. Use high-dose progesterone, so you want your levels to be around 45 nanograms per mil or 150 picomoles per liter for 5 days, and then transfer your day 5 embryo. There are some other little tweaks, and we do use a bit of an immune protocol now as well in some cases, but that's the gist of it. So it is kind of a unique protocol. It's very evidence-based, so I use all of the scientific stuff we've learned from all the different talks we've done here and the things we've learned. But it does actually take quite a bit of effort to get someone with endo pregnant. And it's not just doing the same thing you always do. It does require a greater level of care, attention, and detail. And then the big, question mark in the midst of all that is, do we do surgery as well? So surgery can significantly improve your chances by reducing all the inflammation and the immunological changes. I do encourage people to at least consider it. You have to discuss it with your doctor, but those are reasonable things to look at.
Do estrogen levels after FET matter? How low is too low?
No, they actually don't, so I wouldn't worry about that at all. It's perfectly fine to go ahead with whatever estrogen level you have.
Would a tubular cystic area or a peritoneal
inclusion
cyst be an issue for FET, not hyposalpinx?
A peritoneal inclusion cyst can, if the tube is trapped within it, then yes, it could be because there's fluid in there usually. But if the tube is not captured within it, probably not. But I guess my question would be, why do you have that? Because it's usually a marker that some inflammation has occurred or infection. So I would want to know more details about that to understand that better. I think that would be important. If you're watching on TikTok, by the way, feel free to ask us questions. We do answer them live. I haven't seen any float by, but if I catch them, I'll jump in there.
They're nervous. They're nervous.
They're nervous, yeah. Feel free to ask.
What's more important, how long taking progesterone before transport, or if you start a day or two after trigger FET natural modified cycle?
Natural modified, your progesterone should start with 5 days before your FET, but then you actually need to drop it as you go because your natural egg release will produce progesterone. So as the natural goes up, you want your, what we call iatrogenic, which is us doing it to you. You want the one that you're supplementing with to go down so that they still maintain a level amount. If you continue your normal dose and you also allow your egg to release naturally, you're going to overshoot. And that's fine if you've got endo up to a point, but if you don't have endo, you could overdo it. We got a question. Oh, hi, Jess. What do you feel about counting kicks during pregnancy, especially with twins, specifically with twins? So it's really difficult with twins. Kick counts have been proven to be useful, less so in the twin population, but with a singleton after 28 weeks, what we were always taught and is kind of an accepted standard is 10 movements. It doesn't have to be a kick, but 10 movements within 2 hours. Now, the important thing to keep in mind is babies sleep for about an hour and a half, and then they're awake and then they go back to sleep again. So it's not unreasonable to not feel movement for some time and then feel a flurry of movements. Nevertheless, because I'm not everybody's doctor out there, you have to take all of this with a huge grain of salt. If you're worried about the amount of movement from your baby, go to your local obstetrical triage and get assessed, because you never want to take a chance or a risk, right?
Oh, that's been asked. Okay. If you had a patient that was doing an FET, I swear it's the same question, but there's different numbers in it. But
Okay.
You'll be the judge.
Okay.
If you had a patient that was doing an FET with Neupogen and PRP,
Yeah.
when would you administer each of those? 72 hours before or 48?
It's 5 days for the Neupogen and 48 for the PRP if it's for unexplained failures, as I mentioned earlier. And if it's for thickening, it's a different protocol. So the PRP a month before, the Neupogen is still the same usually, but for the PRP you want to do it a month before. And the the Neupogen regimen for thickening can also be different depending on which study you read.
Very random question. That's the disclaimer of the question itself.
Oh,
that's not my feedback.
The questioner actually said very random question.
Me.
All right, good. Well, to know oneself, right?
Yeah, exactly. But why would someone's anatomy kick out catheters?
Why would someone's anatomy kick out catheters? I need specifics on what kind of catheter you're speaking of. If you mean a intrauterine catheter after surgery, we put them in because the uterus is heart-shaped or T-shaped. And then the uterus will frequently want to go back to normal and reform the scar where we've cut it open. So we go in and we cut the scar open, and then it'll want to close. And if you put the balloon right there and you close, it'll just kind of push it out. So that's probably the most common cause. If you're talking about a cervical catheter for getting ready for labor, it's supposed to come out. So that's what we want it to do. And if you're talking about a bladder catheter, if those come out, something has gone horribly wrong, because if it's inflated and it comes out through your very small urethra, the balloon's usually about that big, and that would not be comfortable at all. The only other kind of catheter is IUI or IVF, but those won't come out. Or I guess SIS catheter, the saline infusion sonohysterogram catheters. So those can pop out if they're not in exactly the right place. That is fairly common. And sometimes we have to put them back in to get it to work properly. Yeah.
I've had 2 medicated IUIs.
Okay.
And never knew my AMH.
Okay.
Because my doctor never had me do the lab in particular?
Okay.
I think it's
Just a
letting you know.
comment.
Just a comment.
Yeah, I mean, I believe that AMH is a valuable test. Not everybody does it, but it's pretty clear that it's a reasonable predictor of your ovarian reserve. It is not a predictor of success. So there are people with low AMH that go on to succeed. But it is a good predictor of your ovarian reserve. And if time is a question mark for you, you need it to be able to understand how much time you have, how many babies can you anticipate, when are your ovaries going to begin to fail, what options do you have available to you. I mean, if your AMH is super low, sometimes that directs us either towards or even away from doing IVF. So I think there are some values to having AMH done. Does everybody have to have it done? No, but is it useful in most circumstances? In most, I believe it is, yeah.
What do you think of taking Provocort daily to help with implantation?
Provocort?
Provocort. Yep.
Never heard of Provocort before, so that one I cannot answer.
Okay.
I have no idea. If somebody knows what Provocort is, please feel free to tell us. If it's a steroid, because it's got the word court in it, then steroids by themselves have never been shown to be beneficial for FET or any kind of embryo transfer alone. But in conjunction with other things, there is some evidence that can be useful.
No comment so far. What is the maximum number of embryos you will transfer in one FET for over 45 years old?
Well, if you're over 45, we would want PGT testing of your embryos. And then if they're coming from your own eggs, 2. So if you put in 2 euploid embryos, I would be comfortable with that at 45 for several reasons. Number one, the chances of success are lower even though they're euploid embryos as age advances. And there's several studies that have shown that, and I think 2 of which we have reviewed on the show. Number 2 is the fact that you're 45 or older, and you probably kind of want to do the one and done thing where you have the babies and you manage, and that way hopefully you're as young as possible for as long as possible for those babies as they age, because by the time they're 15 you'll be 60, and by the time they're in their 20s you're getting to the point where most people are running into trouble with their health. So that's a reasonable reason as well. And then number 3, there is a chance that they won't both work. So you may end up with just one. And so I'm overall comfortable with that in our practice. We still encourage one at a time, but if someone said they wanted 2, I'd be okay with it. That's for genetically tested embryos. Untested, I'd probably go up to 3 for someone 45 and over.
What's more important, do a natural cycle with a random doctor, so the protocol, or medicated with my DR? The technique failed medicated previously post-Lupron.
Wow. So the question is, what's more important, the doctor or the protocol? Is that basically the gist of it?
I'll read it one more time just to make sure.
I'm not sure I caught all that. Yeah.
That's what I think I heard.
Yeah.
I don't, who am I to understand this? What's more important? Do a natural cycle with a random doctor, so the protocol, or medicated with my doctor, the technique? Failed medicated previously post-Lupron. Yeah, that's what they're asking.
Both. So you should never be doing a protocol with a random doctor. You should be doing it with a doctor that understands you, knows what they're talking about, and that you trust, because that's huge. And then the technique is critical. I mean, the protocol does differentiate success versus failure, or at least the chance of success versus the chance of failure. So make sure you're discussing it with a doctor that you have a relationship with, that you trust, that you understand. Candace is asking me what my favorite chocolate is. Candace, you do not need to bring me chocolate, but I appreciate you asking. I love all chocolate though, so I'm good with anything. Don't worry. But you don't need to bring any chocolate. Fire away.
I was going to comment on that previous question, saying if they're just going to go random, I might as well just do it.
Yeah, if you
know
want
what I mean?
random tarks available.
Yeah.
No, that's not a great idea. Hey, Dr. V, what are your favorite restaurants in Windsor?
Oh, there's quite a few.
There's lots. There's quite a few that are good. I'm probably particular to Kebabji because Tarek and I eat that at least once a month.
It is there.
Yeah, Nico Sushi is good. What else is good that we like?
I saw there's
There's the new one, the lemon grill,
Yeah.
which I haven't tried yet, but Tarek raves about.
Yeah, I thought it was pretty good.
Yeah.
You have to have a spice tolerance. There was a lot of sweat.
There's
There's a lot of sweating with that. That was really even when I told them tone it down,
it was still sweaty.
there was still
Yeah.
some perspiration going on. But
Yeah.
but for Indian food, I generally feel that if you don't sweat, you didn't eat Indian food.
Carly. Hi, Carly. I hope you're doing well. And thank you. You're not lost without us. Don't worry. Is NAC supplement recommended? Wow, now all the questions are coming out. Oh, Candace ate at Nico Sushi for lunch. Candace, is it not great sushi? NAC, we continue our NAC through pregnancy. I got no trouble with that, so it's fine. It's good anti-inflammatory.
Okay. In my last retrieval, they only retrieved 9 eggs. Would they retrieve more with another retrieval?
There's no way to answer that without knowing a lot of detail about you. So things that determine the number of eggs you retrieve are the AMH, your antral follicle count, to some extent your FSH, your age, your ovarian reserve, how hard they stimulate you, what protocol they use, the trigger, is it a single trigger or a double trigger, what technique they use at the retrieval, did they flush, did they not flush? So all of those things play into it. So it's not something I could answer just by, kind of saying it on the air, yes or no. I mean, clearly more retrievals means more eggs, typically speaking, but I can't tell you this time you got 9, could they get 15 next time without knowing all those other details about you.
I could probably get 15.
Carly says I look tan.
It's black and white, man. I'm telling you, you went to the beach.
No, it was no beach, I can assure you. Carly, I was outdoors yesterday at the Sachsenhausen concentration camp outside of Berlin. So that's why I have color. It was not a festive occasion for sure, but an important one, kind of a soul-changing one for sure. Yeah.
Spacing of medical Botox for TMJ, not vanity from transfer. Also spacing mammogram.
Mammogram irrelevant. You could do it at any time. That's not a problem. You could have a mammogram while you're pregnant. They just have to put on a shield for you. Botox, like months. You can't have Botox around FET for sure.
Really?
Yeah.
The botulism thing?
Oh yeah,
That's concern?
You gotta.
Really?
Oh yeah. Botox is out. Yeah.
Some nice words here. Northindrome.
Northindrome. Yeah.
Northindrome plus
Yeah.
letrozole should be sufficient to prepare for an FET with endo. Don't want Lupron, she says.
No.
No.
No, norethindrone. I'm not aware of any evidence that says that norethindrone is as effective or even effective prior to FET for suppression of endo, resulting in a benefit. Yeah. Candace is asking if a headache is normal after you trigger. Could be, plus you flew. So there's a lot of different reasons to have a headache. You can take Tylenol, it's safe. Just don't take ibuprofen, it can prevent ovulation.
Treatment for breakthrough bleeding on 3-month Lupron protocol?
Oh, that's tough. So usually what we use is either estrogen or progesterone or both. You want to avoid estrogen if you're taking it because you have fibroids or endo. So you could try some progesterone, but speak to your RE because that's important to figure out.
Are chemical pregnancies considered miscarriages, or a form of implantation failure?
A chemical pregnancy is not an implantation failure because you actually did get pregnant. So it's a form of miscarriage, basically. Yeah. You were pregnant, it's just that it didn't continue. Most likely that's a genetic thing, but we don't know, obviously.
There's a rumor that you might be hard to hear. Want to angle that a little bit?
Sure.
See if that makes a difference. And then let's see.
Is that any better?
Yeah, let's see now. So yeah, ask that one more time.
How's the sound, guys? Give us some thumbs up if the sound is good, or hearts, or whatever it is on whatever
Thumbs
application.
up, hearts, absolutely.
Thumbs up, hearts,
give us
whatever.
anything you want.
Yeah.
Also asked, interestingly enough, is cannot be taken once pregnant, but you
I answered that one.
answered that,
Yeah.
right?
Yeah.
If you're doing uterine PRP to increase uterine receptivity but don't need help with lining, would you still administer a month prior?
No, that one's 48 hours prior. So for lining thickness, you can do it 48 hours prior, and that's what the study showed. But a lot of people who do it actually see a benefit a month later. For non-lining thickness, for like recurrent implantation failure or implantation problems, you're supposed to do it 48 hours before. Yeah. I got a thumbs up on TikTok, and that it's better on TikTok, which is funny because usually it's worse on TikTok.
It's always something.
When do I stop PIO shots with pregnancy? We stop them at 12 weeks. It's totally torture and I feel awful, but I don't like messing with it till the placenta is fully taken over, which is between 10 to 12 weeks. So we do it at 12 weeks.
What is the recommended treatment for thin lining prior to FET?
We went over that at the beginning.
Okay. Oh, really?
Same person?
No, different. Risks of PGTA testing as to potential pregnancy, placenta, or birth defects, etc. Thanks.
No, there are no risks to the baby or the embryo other than that they could damage the embryo from doing PGT testing. Outcomes of live births following PGT testing are equivalent in almost every study that has looked at it. There may be a slight increase in small for gestational age babies and preeclampsia, but that's it. And they're not sure yet. So as far as we know, it's pretty safe. Carly is asking if there are any complications that can happen from having an embryo transfer shortly after a birth. And the answer is, as long as your uterus is normal and you've had at least one period, there is no evidence that there is any compromise. Should I remove my only tube, left tube, blocked before IVF? That very much depends on why it's blocked. If you have a hydrosalpinx, it has to come out before you do IVF. Before you do your embryo transfer, because it's a 50% reduction in success. If you're doing it because it's just blocked, but there isn't hydrosalpinx, which is fluid inside the tube, you don't need to worry about that. So that's not a big deal. And then again, I'd still want to know why it was blocked. Like, is it tuberculosis related? Was it endometriosis? Was it a previous PID infection? That kind of thing. I got more here. Is that okay?
I don't know.
Is ICSI linked to preterm labor or PPROM? No, there is no association I am aware of between ICSI and PPROM or preterm labor.
Is it safe to take baby aspirin through pregnancy, or should you stop once pregnant?
Yeah, actually, after years of recommending baby aspirin to pregnant patients, it is now officially part of the new recommendations for pregnant women to avoid complications in pregnancy. So,
really?
Yeah, just yesterday actually that came up.
It's an official thing now.
It's an official part of American college guidelines to offer it to women at risk of preeclampsia. But it actually is good for preventing preterm labor. So I think when they finally get around to it, someone will actually go over that benefit as well. We have a great video on aspirin. So watch the YouTube video on aspirin on our YouTube channel. It'll explain to you what to do and why.
Partial match. Does that mean we are related? What are your steps for treatments?
Does it say what they're a partial match for? DQ alpha? It definitely doesn't mean you're related. God forbid, that would be bad. Yeah, so there are things that you can do that help with that. It's a long discussion, so that's something where I would recommend you discuss it with us. And I also need to know what you're a partial match for. But there are things that can be done for patients with DQ alpha match, if that's what you're a match for. Any advice for a first-time mom expecting twins? Sleep while you can. Listen, twins are a lot of work. You need support. So make sure you have a good support network, mom-in-law, sisters, cousins, friends, people that can come in and help you. Make sure your home is organized. Make sure you don't lose yourself in the process. Make sure dad's or mom, whoever else is there, is participating and helping. You're not going to be able to manage it all on your own, or at least I would try that very frequently. So yeah, make sure you're taking all the right precautions. What is the difference between implantation failure and chemical pregnancy? Chemical pregnancy means you actually got pregnant. Implantation failure means you didn't. That one's easy. Yeah.
Had normal SIS nearly a year ago. Now getting ready for my first transfer.
Okay.
Need SIS repeat?
Yeah, I would. I'd say 6 months for sure. Recommended treatment for recurrent high estrogen levels with no obvious cause. See a reproductive endocrinologist because we'll probably be able to figure out the cause. There's a lot of potential causes. Should I be concerned that my temperature gets to 101 very often? It depends on why it's getting to 101. So that's a see a doctor question for sure. Not something I can answer on IG, but yeah, I mean, that's a high temperature. So I'd want to know why you're going that high. Oh, one more. Do I deliver my IVF babies by 39 weeks? Does this mean your patients will be induced? Yes. It is safer to induce patients at 39 weeks, in particular IVF patients, but all patients actually. So if you read the ARRIVE trial or watch our induction video on YouTube, it's very clear that induction is better than natural. So we encourage people to consider it. We don't force anyone, but I definitely encourage it.
I'm telling you, it's better on the phone.
Yeah, you mean more interaction?
Oh yeah. Somehow it's rigged.
Well, why is it?
I don't know why, but
That is weird. Maybe
right?
It doesn't promote it when it's.
I really think that's what it is.
No, as long as it looks good, that's okay. Yeah.
Have you had any patients with recurrent high estrogen levels with no obvious cause? If so,
That was asked over here.
Oh, they're jumping.
If so, what was it?
If so, would you suggest proceeding with IVF?
You need to see a doctor. So I need to know why you have high estrogen levels. And high estrogen levels shouldn't preclude you from getting pregnant. So you need to see a doctor for sure.
Hello, Dr. Veen Tarek. I came back on that. They remembered I exist. They remember.
You're back.
Yeah.
All right.
Is a cervix length of 2.5 at 12 weeks too short? I'm already on 800 milligrams of progesterone since 4 weeks. Should I increase progesterone or go for a stitch?
I can't answer personalized questions like that. Is 2.5 centimeters short? It is right at the margin of being short. Although at 12 weeks, I think anybody would consider that relatively concerning. So I would definitely be following up with an obstetrician to see what they recommend for that. Or if you're in the US, a maternal fetal medicine specialist. So yeah, that requires someone with a lot of experience to go over your history and determine what the right answer is for you.
Would timed intercourse have the same success rates as IUI?
No. Timed intercourse definitely does not have the same success rate as IUI. IUI improves your success rates. Even in a natural cycle, IUI can improve your success rates. Can anxiety medication affect a period? Depends on which med and your dose, but yes, it's possible. Did that not just sound like a ship coming in?
I was wondering what that was.
Yeah, that was weird. You heard the same thing I did, right? It's probably a truck breaking or something, yeah.
Hi, Dr. V. I had 19 eggs retrieved on Sunday.
Woo!
12 were mature.
Okay. Trigger
was 10,000 HCG.
Whoa!
What went wrong, or is this a decent maturity rate?
I'm curious as to where you had your retrieval, because most people don't use 10,000 of HCG, especially when you have 19 eggs, because that can cause hyperstimulation. So we have studies that show that a double trigger does increase your success rates, although you can't use it for everybody. So double trigger with a GnRH agonist and some HCG will increase the number of mature follicles. Delaying a little bit in the retrieval time can increase the number of mature follicles, but it's not uncommon out of 19 to have 12 mature. So that's actually a very good number. There are studies that show that the optimal number of eggs to have is actually 12. So that's a good number. You should be really happy with that. Congratulations. You get my thumbs up if nothing. I can't do it electronically.
No, you cannot.
I can't give myself
you
thumbs.
the real thumbs.
Okay, give my real thumbs. Recommendations for high anxiety during the first trimester: light exercise, meditation, yoga, prayer, natural stuff. Bananas, warm milk, they raise your serotonin levels. It's literally like taking an antidepressant without taking all the meds, so that's reasonable too. There is a theory you're the doctor on the side of penalty box restaurant. No, that is 100% not true. I am not the doctor on the side of the penalty box. I don't actually know who that is, but it is not me, I assure you. Yeah, yeah.
How important is sperm morphology if all other numbers are good, but only 1% morphology?
Pretty critical. I mean, abnormal sperm theoretically don't work. So essentially you're eliminating 99% of your sperm count. So yeah, it's important.
You have to read that. That's the best thing I've ever read in my life.
Oh, I love it. That's pretty cool. So we have a message from Candace saying, I almost made T a makeshift lab coat and sewed aspiring Dr. T above where the chest pocket goes. You know, I should do that for you.
That's pretty good.
Yeah.
That's pretty good. There's some good jokes in here.
I should get that on a t-shirt with an arrow pointing towards you. That's pretty funny.
Can DHEA and Rodrol cause a small amount of weight gain or water gain? P.S. You're not allowed to say no.
Can DHEA and what?
Androgel.
Oh, androgel.
Yeah. You're not allowed to say no.
I'm not allowed to say no. Well, I can only say, I won't say no. I will say I have not heard of that side effect. Water gain or weight gain?
Any gain.
Well, weight gain for sure. Water weight gain, I haven't heard of that. Although human growth hormone, we've had a couple of patients that's retained some water. So if you're on that as well, it certainly could contribute. Someone mentioned it's Eli Malice who's on the side of the penalty box.
We got a whole conversation.
So there you go. Yeah. Dr. Malice is a good doctor.
Hello, the sweetest and the kindest doc.
Aw.
This is all you.
Are they referring to you?
No, unfortunately not. Because there's followed up by real questions.
Okay, all right.
What do you think of this modified natural FED protocol?
Okay,
Baby aspirin,
great.
day 12 ultrasound, Overdrol on 18 millimeter follicle.
Day 12, nothing before then?
That's
Okay, we monitor more than that. Trigger on an 18, reasonable.
PIO injections 2 days after HCG continued.
Yeah.
7 days post HCG. Embryo transfer. My clinic doesn't do any pre-treatment for possible endo. Is this my best option for an FET?
Not in my opinion if you have endo. I wouldn't do it that way at all, actually. And the HCG thing can be problematic, and it's also unnecessary. And the 18 is forcing you, but you don't know how thick your lining is. So no, I can only tell you I don't use that protocol. And certainly if you have endo, arguably there are better protocols that can be used with science to back that up. So you should probably reach out to us and chat with us. It's info@drvictory.com. just click the link and or on our website, our newly revised amazing website. Thank you, aspiring Dr. T.
Yeah.
Um,
Can I not?
on literally every page it says book a consultation, so just contact them from there and we'll happily do that.
Hi, Dr. V.
Dr. V.
Is there anything I can do to improve malformation of the acrosomal or lengthening neck pieces?
Of the
Thanks in
sperm?
advance. I'm assuming that's right.
Yeah, vitamins, frequent ejaculation. I don't know if cold therapy would work, but it won't hurt. No smoking, no drinking, no drug use. And when I say no drinking, I mean zero. It's an 83% increase in the number of abnormal sperm when you're a drinker. So avoid everything bad. Take lots of vitamins. That should help. It depends on the specifics of your circumstance, but that's in our video on YouTube as well. So check that out.
The protocol questions followed up with, they just need your opinion only. They won't take that as a medical advice. No worries. And my clinic won't add letrozole as he says there is no benefits to adding it.
Oh, well then switch clinics because your doctor doesn't know what they're talking about. I mean, like denying the validity of letrozole to me personally is insane. There are so many studies showing that it is beneficial. And for a endometriosis protocol, again, low estrogen, obvious. You don't even need a study for that. High progesterone, demonstrated in a study we reviewed recently. The supplements, there's no data to show that it increases success rates with FET, but we do use them and we have spectacular success rates. So I think it works. Surgery, all of those things are valid. Would I just do natural with HCG at 18? No, it's in one ultrasound, it's like a super caveman approach to an FET. And for what you have, based on what you've told me so far, you need a far more sophisticated approach. So my advice would be switch clinics or doctors.
Does an IVF cycle include all the embryos to be implanted in the cost?
Well, we have one like that, which is a guarantee cycle. So we keep implanting all of the embryos you make from one cycle until you have a live birth. So that's a special package we have. But unless you've got government funding. Now, if you have Ontario government funding, which by the way, we do have available. So if those of you who are watching the show need a funded cycle, reach out because we do currently have some funding available. And we'll be reaching out to our existing patients who are undergoing IVF. So if you've got a government funded cycle, we are obligated to transfer all of the embryos till you're done with those embryos from one cycle. So it depends on whether it was private and which package you selected, or if it's funded, which covers all the embryos, like forever.
If lining has failed to thinking during multiple FET cycles, including mini-stim, but thickings during egg retrieval, would you recommend a fresh transfer for high responder?
No. So we've presented on that and actually just recently had really great success with a patient who flew all the way from out west because her clinic wouldn't listen to her. And we literally got her pregnant with our protocol when they couldn't out west because they could never get her lining to thicken. So just 75 units of Gonal-F per day is actually enough to get someone's lining to thicken without getting their estrogen levels sky high. So that's a reasonable approach if you've tried everything else. But there are a lot of things to try, which we mentioned right at the start of the show because it was the opening question. PRP, Neupogen, human growth hormone, vaginal Viagra, vitamin C, D, E, pentoxifylline. There's all sorts of things that can work. So don't hesitate to, talk to us and get some advice. Just reach out to info@drvictory.com, do a consult with us. We'll help you through it.
Would you suggest either IUI or timed intercourse with ovulation medication for someone who has had multiple miscarriage while waiting for a consult or not?
Not if you've had multiple miscarriages, I would wait. IUI definitely does not reduce the rate of miscarriage, so it would be unethical for me to tell you to do that because that just doesn't make sense. Maybe if you were using a device to reduce sperm DNA fragmentation, but that's a maybe. Timed intercourse, if you just want to get pregnant, sure, but I usually tell my patients to stop trying until they've had their consult so that you're getting the best care possible. After how many natural monitoring cycles would you suggest IUI? I don't believe in natural monitoring cycles, generally speaking. There are some instances where it's useful, but it's a device used by a lot of fertility centers where we end up making a lot of money and it's a very limited benefit to you. If you're having sex every day or every 2 days around your ovulation, somebody needs to explain to me how it's beneficial to do timed intercourse. It doesn't make any difference. The sperm lives inside a woman for 3 to 5 days. Who cares if I monitor it with ultrasound and blood work? Do we make money off of it? Loads. Is it practical for you to do it multiple times? I've never understood why centers do that. I'd love to hear a valid explanation, but I have yet to hear of one. It doesn't make sense to me.
Do all labs use the Zymo chip, and does your lab use it?
Yes, we do. I don't know about all of them. I can't answer that.
Is it safe to do HSG in the weeks before transfer?
I guess it would depend on how close in the weeks before transfer. I wouldn't do it in the same cycle, but otherwise, sure.
What can cause AFC count to dramatically increase after a few months? Could it be supplements and healthy lifestyle?
Yeah, for sure. Removal of birth control, weight loss, supplements, DHEA, testosterone. I mean, it depends on how much it jumped, but yeah, that can definitely help.
If I had two mature follicles for IUI but ended up pregnant with triplets, would that mean an egg split and form two babies, or any other explanation?
Well, sometimes smaller eggs that you don't think are mature and aren't being counted can actually be mature. So I think it was up to 19%, don't quote me on this, because it's been a long time since I've looked at the study, of follicles 12 millimeters can actually be mature. So they may have seen it and said, don't worry about that one, but actually it took. Or one of them split into identical twins, like you said. So yes, that's possible.
Timing of an FET after the third Lupron shot, endo protocol.
It should be started 30 days after your last Lupron shot. So, but it requires some finesse because you got to extend letrozole 5 days past it if you're doing it the right way, in my opinion. So yeah, the following month after your last shot.
Hi, Dr. VNT. I'm 35 weeks.
Oh, wow. Cool. Congratulations. Yeah, we had, did you see that post I put up? That was cool, eh? Yeah, we helped someone that didn't even know us. So I love that. That's kind of neat. I thought we'd get more attention to that post, but anyways.
You never know what...
it's kind of whimsical.
You're just throwing it.
I know.
3 times endometrium, is it enough with natural transfer with HCG on the 22 transfer on 29? When to test?
On the 22 transfer on the 20, I don't know what that means. But if you're taking endometrium alone, there are studies that support a better outcome when you use a combination of oil and vaginal. Having said that, you're actually going to be producing progesterone on your own because you're doing a natural with a trigger. So there isn't a lot of evidence for that. I don't know that it would be mandatory, and we do find with people that release eggs that we do need to drop our progesterone and oil to accommodate for the increase in their natural progesterone. So it's kind of hit and miss.
Thank you so much for creating this educational content with us.
Oh, my pleasure.
It is unbelievably helpful.
Oh, good. I'm glad to hear that. Thank you. Thanks for watching, guys. It's awesome to get the chance to keep doing this. So it's very fun. We still have a good time. Although I missed, we usually eat together, and I didn't get back until like 7:45. So
I suffered.
You did. Yeah, I feel bad. Can SIS ultrasound show if the fallopian tubes are blocked? Yes, for sure it can. Absolutely it can.
When do I stop collecting embryos? 3 FET euploid failed, 1 euploid left, 41 years old, had 8 egg retrievals already. When is enough?
Whoa. Well, that's a lot. I guess I would highly recommend you discuss it with us so we can figure out what's wrong so that we can do the best job possible for you. But I most certainly would not recommend just doing more retrievals without knowing why you failed 3 euploid embryo transfers. So that's a detailed question. Again, info@drvictory.com. We're getting a very, very, very high success rate with euploid embryos. So I think the College of Physicians and Surgeons of Ontario doesn't want us to share our actual success rates. But I can tell you that my target is 80% per single embryo transfer, and that we are exceeding our target. So if you're failing, I would want to know why.
PGC tested day 5.
Okay.
3AB medicated transfer failed.
Okay.
Used an antihistamine protocol with Neupogen and HCG loading, also time transfer with your good friend ERA. What should be done for the next transfer?
You need to contact me and I need to go over your history. So that's a lot of stuff and I need to know how you got to that point. It's not something I can answer on IG. It's a very fair question and it does deserve a good answer, but to give you a good answer, I need to know you and your history. So once again, info@drvictory.com. It's going to be a catch line. We should just, you know what, you should run that along the bottom.
Well, I have, this is not considered, I got that running.
Can you just, so just add another line that says in between. Yeah. So yeah, just contact us and I'll happily go over it with you.
Do you know the current average weight for a surrogate in Ontario?
Yes, I do. Anywhere from about 6 months minimum to about 24 months if you're not having good luck or your scenario is more complicated than normal.
This is a very interesting question.
Okay.
My friend is 7'1".
7'1"?
Mm-hmm.
Whoa.
Healthy and active.
Okay.
But why is he always getting injured?
Where do you come up with this stuff?
I'm just reading.
I don't know.
I don't cherry pick these.
He could be acromegaly, which is a growth hormone condition. Maybe he's clumsy. I have no idea. The 7'1", I mean, you're probably walking into stuff.
That's what I wanted to say.
I don't know.
Nothing fits.
Yeah, that can't be easy.
That can't be easy.
Yeah, no idea.
Every door is just
7'1", you'd be ducking all the time.
all day. 100%.
Yeah, ducking all day.
There is many brands out there. What was that?
I hit the keyboard by
okay,
accident.
okay.
Yeah.
There is many brands out there.
Yeah.
They claim that they can detect the baby's gender as early as 6 weeks.
Oh yeah.
By testing the DNA and the chromosome in your bloodstream.
Yeah.
Do you think that the results are accurate?
No, not at 6 weeks, but after 9 it is. I've never heard of anyone that can do it at 6, but maybe someone's developed some newer technology. After 9 weeks, the NIPT will detect it and it's very accurate.
What do you tell your patients about getting a Botox a couple months before transfer?
Don't.
There you go. Nice and easy. You know, it's funny because you just start, like, there's a lag on Instagram from when we're going live and when it's going here. And you just laugh now when I said duck. And it was funny the second time as well. It was a funny moment. Oh, great question.
Okay.
Can I take Ozempic for weight loss while doing egg retrieval and IVF? Or would it affect the egg quality?
No one knows. It's too new. I wouldn't though. I'm not a believer in doing Ozempic for weight loss and it does have significant side effects. So weight loss is easy. It's math. It's diet and exercise. If you take in less calories than you burn off, it is biologically and physically impossible not to lose weight. So you just have to be negative. So if your calorie intake is 1,500 and your calorie burn is 2,000, you're going to lose weight. You don't need Ozempic.
How much calories do you burn if you do nothing all day?
Normal daily activities, like normal daily
like-
activities, go to work, come home, whatever.
Yeah, go to work, go home.
It depends on who you are, but
Let's say you're me.
you're probably around 2,000.
It is 2,000, right?
Yeah,
Yeah, okay.
you're probably around 2K. Yeah. Well, you're chasing your kids around, man. Like
There's a lot of chasing.
there's a lot of
There's a lot of
kids to chase. Yeah.
How much would IUI help with low sperm morphology?
Depends on how low the morphology is, but reasonably it helps a little bit. Yep. It's not really targeted towards low sperm morphology, but it does help. If you have very low morphology, we'd probably encourage you to consider doing IVF. So that can help a lot more because then we can pick the normal ones to use. We seem to be stuck all of a sudden on TikTok.
I noticed that.
We're like flush. I don't know. Maybe no one else joined because they know the show's almost over.
Yeah, they got depressed. It's like, damn it, this guy's almost done. Hi, Dr. VNT. Is OHSS common on Clomid 50 milligrams if you have a high AMH and antral follicle count?
No. It would almost be unheard of to take 50 milligrams of Clomid. There are case reports of OHSS following Clomid, but case reports, like you're talking handfuls, not high numbers.
I just want to see. It goes.
Okay. Oh yeah, because you.
Yeah, I just wanted to see. What the heck? Ola again. Talking about the monitoring, how many times or what specific dates do you like to perform ultrasounds? Just to have an idea to talk to my doctor to be able to report back to you.
For FET?
Yeah.
So we'll do a baseline on day 3 to make sure everything's normal. And then usually like 6 or 7 days later, although my nurses like to bring you in more than that, but I don't think you need to come in until 6 or 7 days later. And then after that, it depends on what things are showing. So it very much depends on how things are going. Yeah, it's definitely working.
Yeah, just wanted to make sure. What is your success rates with IUI?
It depends on how it's being done. And you can't really answer questions like that. I mean, success rates with IUI in a young person can be, 15 to 20% with pills and 25 to 30% with shots. In an older person, it might be as low as 5%. So it's not something you can just kind of blanket cover and say, my success rate is X. I can tell you our average success rates are right in line with the literature, which is 10 to 15% when you're using pills in IUI, 20 to 25% with shots.
You are amazing.
Thank you. It's only because I work with great people like my good friend Tarek here.
I'll take that. That's good.
1 minute left. Tarek's
Okay.
terminal question.
All right, here we go.
Do we have a lot more, or are we done?
No, you're good. You're a lot
Kinda-
more is a big word, but you're okay.
Okay.
First
Fire
day
away.
back, you're jet lagged. You're
I'm a
tired.
little jet lagged. Yep.
Yeah. Okay, ready?
Yep.
Terminal question.
Yep.
Here it is. I'm 9 weeks pregnant,
Okay. Congratulations.
obviously.
Yeah, I figured it wasn't you. Yeah.
and I don't
We'll
feel
be having
nausea.
a long talk after this.
Yeah, and I don't feel nausea anymore,
Okay.
but have other symptoms. Should I be worried or not? I had a miscarriage last year around the same time. Thank you so much, Dr. Victor.
Nausea is not a symptom that should be used to gauge the health of your pregnancy because it is dependent on many different factors. But anytime you are worried, go see your doctor, a simple ultrasound, and you'll have your answer. So if you're concerned, see your physician, but we don't use nausea as a gauge as to the health of your pregnancy, for sure. Okay, so next week, I have no idea where I am, so we'll let you know where we are next week. And see you in the AM, Candace. Yes, I will see you bright and early. Hope you're all well, and thank you again for watching the show. We love you all. If there are hot topics you want to know about, it seems like maybe next week I should just do like a video on ways to thicken. Maybe we skip like like an article, but we do a topic.
Oh yeah, that's nice.
Like methods to thicken
Yeah,
the lining.
yeah.
So maybe we'll do methods to thicken the lining of the uterus, and we'll turn it into a video for you on YouTube. And but if you have any other topics you want to know about, let us know. One of our readers, I can't remember who it was, recommended the ALA one. That hopefully will be up soon. You're still working on that one, right? Because I
Did
don't
we do
think.
it?
No, that was the one where you weren't there. Remember?
Oh yeah.
We got to post that.
We gotta post that one.
So, anyways, we'll see you hopefully next week, guys. I hope you have a great week. And to all those of you who are struggling with this, let us know if we can help. We're always happy to help out in any way that we can, even if it's just mental health resources. We have loads of those. So, info@drvictory.com. We'll be happy to help you out. Don't do the ERA test.